Great, thank you again for joining. My name is Nicole Weber, and I'm a Senior Specialist for Capacity Strengthening and Learning with ProWash. We're really excited to be putting on today's webinar with Amalima. So on the ProWash side, we have myself as well as Rebecca Pinto, who will be moderating the chat box today. We also have Julia Randall from Ideal, who is supporting us on communications. Today's webinar is focused on integrating savings and income generating activities into community health clubs to improve latrine construction in Zimbabwe. This webinar really comes out of work that we, along with Ideal and Tango International, have collaborated on with Amalima in Zimbabwe over the past year. And so we are excited to have Pamela Wellington Nja from Amalima, who will be presenting during the first half of today's webinar, the bulk of their work from qualitative research that they have conducted over the last year, as well as some broader lessons learned from implementation. During the second part of the webinar, we have Karen and Elizabeth from Ideal and Tango International, who will be discussing a little bit more about Amalima's experience with qualitative research for WASH, as well as some more general tips around using qualitative research methods for looking at WASH outcomes within development food security activities. And so with that, next slide. We're going to go ahead and get started. There will be ample time for questions and answers after both of the presentations. And so feel free to please use the Q&A box to drop any questions you have during Amalima's presentation or during Karen and Ellie's presentation and discussion around qualitative research in WASH. The webinar will last approximately 60 minutes. The recording and presentations from today's webinar will be shared with all participants. You will be muted the entire time, but feel free to, share your experience in the chat box. If you have done qualitative research or you're interested in qualitative research for WASH, we'd love to hear more from you. And we also would love to have all your questions in the Q&A box. And so with that, just to kind of see who we have in the room today, thank you so much for taking our poll. It looks about a little bit over half of people attending today's webinar have used qualitative research methods to capture outcomes from WASH work, and about a third have not, and 12% are not sure. So for those of you who haven't yet done qualitative research, we hope that some of the tools and examples that are provided today might be of interest. And for those of you who have already used qualitative research methods, again, we'd love to hear more about this in the chat box. So without taking up any more time, I'd like to turn it over to Amalima and their presentation on these integrating savings and income generating activities into community health clubs. Next slide.
Hello, everyone. So the Amalima program is being implemented in Zimbabwe. The prime is CNFA, and there are a total of 5 consortium partners. The program is funded by USAID Food for Peace. Next slide. Next slide. Okay, so Amalima is a 7-year program, and Amalima is actually a Ndebele word that describes the coming together of households and families, their ideas together, their resources, their labor towards a shared objective. And it has 3 strategic objectives. The first strategic objective looks at agriculture activities. The second one focuses on resilience. The third one looks at nutrition and health. The Amalima program is being implemented in Matabeleland North and South, which are in the southern part of the country, across 4 districts, Cholocho, Bulilima, Mangwe, and Gwanda. And it's being implemented in a total of 65 wards. So a district is divided into a ward. And a lot of these districts actually close to the borders, close to South Africa, close to Botswana. So you have a situation where you have high migration in terms of economic migrants, and you have remittances being poured back into these districts. In terms of the climate, these are areas with low rainfall patterns, and in terms of the economy, over several years, Zimbabwe has been facing a lot of economic challenges. So that's just to give you the sort of context in terms of the areas that the Amalima program is being implemented in. Next slide. The program is national partner driven in the sense that local NGOs are the key partners on the ground that are doing a lot of the actual implementation on the ground. So all the field officers that are implementing the activities are local NGO staff. We use a group approach. So a lot of the activities take in groups, whether it's training or other activities. Particularly key about the program is that there are no free inputs. We use a cascade approach for implementation, where there's training of trainers. We work in collaboration with different government stakeholders, for example, Ministry of Health, Ministry of Agriculture, and training is rolled out to communities using different community volunteers. And so the volunteer approach really underpins a lot of what we do. Comprehensive coverage in target areas. If we're looking at the community health clubs, we are in 61 of the 65 wards that the program is being implemented in. Integration is very core to what we're doing. So we have strong, for example, strong nutrition agriculture integration, strong nutrition wash integration, and so forth. We're reaching the poorest of the poor as a program. And we work very strongly, very closely, collaboratively with Ministry of Health and other development partners. And gender lens, so gender sensitive, gender responsive approaches, that's very key for the program as well. And through a resilience lens, because the need for learning to improve as we implement, adaptive management is also key. And next slide. So looking at the end of project evaluation findings for Amalima, the baseline was conducted in 2014 and the final evaluation was conducted in 2019. So as you can see, we pulled out some of the indicators there: stunting reduction, 7 percentage points reduction, and then looking at a percentage of children under 5 with diarrhea in the last 2 weeks. Also dropped down by about 5 percentage points. And then a very big increase when you're looking at percentage of households practicing safe storage of drinking water, very reflective of some of the practices that are being taken up by communities, from 49.7% to 98.4%. And then percentage of households using improved sanitation facilities, that's also increased from 40.6 to 53.6%. And a lot of these WASH improvements are likely attributable to some of the strong hygiene education and promotion that is happening through community health clubs. Next slide. So looking at the program outcome survey findings, in terms of the hygiene promotion activities, we've trained over 52,000 individuals in the communities within the 4 districts. And in terms of the practices that have been taken up, such as construction of hygiene enabling facilities, about 14% of households have constructed latrines. And then we have a higher percentage that have gone on to construct the pot racks, and about 40% that have constructed TP taps, and 40% as well constructing refuse pits. Next slide. So the next slide, the community health clubs, where we'll talk about the hygiene promotion activities. So the community health clubs are really participatory community level hygiene promotion groups. And their objective is really to support the uptake of key WASH behaviors and practices at community level. And this is the core activity that we've been undertaking to improve hygiene promotion within the communities. Training undertaken in groups, and to date, Amalima has established a total of 525 community health clubs in the 4 districts, and we have trained 260 community-based facilitators, and the training has happened with strong collaboration with Ministry of Health at all levels. Next slide. Next slide. The next slide looks at the key features of the Amalima Community Health Clubs. So in terms of the resources, we have the Community Health Club Manual, or a CHC manual, and we also have a participatory health and hygiene education toolkit that is used for guided sessions. The CHC participants use these manuals and they use the toolkits. The facilitation is done by the community-based facilitator or the CBF during the Community Health Club session. And so a lot of the learning is very engaging, very participatory, lots of use of drama, lots of use of songs, and it contributes to the strong group cohesion that we see within the CHC. I indicated earlier, no subsidies are given for latrine construction. And once the CHC members complete the set of the different modules that they cover as part of the PHHE sessions, they graduate. CHC then makes a decision whether whether the members want to embark on a VSNL or IGA activity. VSNL is village savings and lending, and IGA is income generating activity. So they embark on this with the objective of financing latrine construction and other hygiene improvements. Moving on to describe the health club approach. Next slide. Next slide. So the next slide is looking at the community health club approach. So project nutrition and WASH officer, this is what happens at district level. You have your project nutrition and WASH officer who works very closely with the Ministry of Health District Environmental Health Officer. They deliver the trainings and support the field officers to make sure that field officers are trained on the PHHE approach, participatory health education. And we have a total of 9 field officers per district. These field officers work very closely with the Ministry of Health, Environmental Health Technician, who is clinic-based and supports these activities at ward level. The field officer, together with the Environmental Health Technician from Ministry of Health, then go on to support a total of community-based facilitators. The community-based facilitators are Ministry of Health village health workers that are based at community level and reside within those communities where they start up the health club activities. So on the Amalima program, we have 1 community-based facilitator supporting 1 to 2 community health club meetings. And these health club meetings take place on it ranges from a weekly basis to about once every 2 weeks, where the members come together and session is delivered. So once they graduate, like I indicated, they then make that decision to join a VSNL or Village Savings and Lending Group in order to be able to raise finance to contribute to latrine construction. Next slide. So the next slide is looking at the CHC approach and adaptations that we have made as Amalima program. So capacity building, supported supervision, this has been key, this has been core from the startup. On community leadership, participation and support. So we have community leaders that actually take part in the CHC activities, and their members in this heightened visibility, heightened appreciation in terms of hygiene promotion activities within the community. Strong collaboration with Ministry of Health, because the areas that we're working in, these districts are sparsely populated, we have smaller groups than the average size of a community health club. So the groups can range from about 10 to 15 members, but because of the strong edutainment and the participatory approach, the groups are engaging and the interest is heightened as well. We have leveraged on the program's male engagement strategy. We have a very innovative strategy that we've been running with, and this has helped us to look at ways in which to get men to participate more in promotion activities. I've already talked about the integrated approach. It has been core to what we're doing, and adaptive management as well, key for learning for improvements as we implement. So the next slide is really looking at the qualitative assessment. So in terms of the research that we actually conducted, so the objective was has really been to investigate the integration of savings and lending and income generating activities with CHCs as a model for improving the uptake of latrine construction. So we had 3 key research questions when we undertook this research. The first one was, do CHCs integrating savings and lending and income generating activities, which we're calling CHC plus, an improved uptake of latrine construction compared to CHCs without integration, so your standard CHCs. The second one was, what motivates, looking at the motivating factors, what motivates CHC plus to construct latrines, and what limits CHCs that have graduated, that are not actually diversified into BSNL and IGA to construct latrines. Next slide. The next slide looks at the methods for the qualitative assessment. We use the mixed method approach, focus group discussions, key informant interviews with environmental health technicians from Ministry of Health, with agri-techs staff on the ground, as well as with the community-based facilitators themselves. We also conducted observations with a sample of households from some of the CHC groups. Next slide, please. The next slide looks at key results from the assessment. So in terms of key results from the assessments, in responding to this research question, we conducted an analysis of the program outcome monitoring data, and it showed that when we look at CHC members from the CHC plus, these are the ones that have integrated BSNL or IGA into the CHC activities, they have constructed more latrines than those from standard CHCs. So out of 158 CHC households that had no latrines before joining the CHCs, at least 59% have constructed and are utilizing the latrines. Whereas out of 160 households of standard CHC members, only 32% have since constructed latrines. Next slide, please. So this next slide looks at key results and lessons from the assessment. So really looking at the key motivators for latrine construction. So the key motivators that came up tops: financial, social, human, and animal health benefits. This was key for the communities, for the CHC groups. Disease prevention, an issue of shame and embarrassment on practicing open defecation. And this seemed to be something that was very common in the communities, because community members or CHC groups would come up with different messages and different songs, actually looking down on the practice of open defecation. And some of the key motivators were linked to traditional beliefs around open defecation. For example, people citing that they've heard that some people still human fecal matter for rituals, for enrichment purposes. And this was something that was new for us as a program in terms of some of these traditional beliefs that were coming up. Concerns around cows and chickens eating fecal matter, health-related concerns, obviously. And then in most communities where community leaders were encouraging or enforcing community bylaws, this encouraged construction. So in some of these communities, the bylaws were related to construction of that structure before one can actually start constructing the rest of the huts or the home. homestead. Factors such as access to materials, husbands and local leader support were also mentioned as enabling. When we look at the key difference identified in motivating factors for latrine construction between CFC plus and standard CFCs, it was really that the CFCs that were doing VSNL and IGA had access to money from the VSNL or IGA activities, and this access money was what contributed to the latrine construction. Next slide. So the next slide is looking at what made it easy to construct latrine construction. So financing from VSNL, availability of cement at local markets, working as a group. So this came out very strongly, it was mentioned by a lot of the groups, the social cohesion, the group cohesion, availability of skilled builders within the community, access to locally available resources, or easy access to a soil type that could be molded into bricks. The social support, perceived social cohesion, it seemed to be much stronger with CFCs that had gone on to embark on VSNL and IGA activities. They had a spirit of supporting each other. And then one of the CFCs, Zaneni CFC, had actually raised chickens through a poultry project to fund latrine construction for both club members, and had gone on to do this as well for community members who did not have latrines. So we're seeing the social responsibility aspect also coming out of that. Slide, please. So the next slide looks at barriers to latrine construction. And some of the barriers include lack of cement, lack of cash to purchase cement, lack of water for brick making, lack of local leadership enforcing the building of latrines by communities, and the general sort of behavior change challenges that you would get from a community, the late adopters and so forth. Next slide, please. The next slide looks at key learnings. So what are some of the key learnings for us program? So what's really been important from this whole experience is engaging with ministry counterparts to ensure sustainability. That has been key. Dedicating time and resources to sufficient capacity building, the supervision, from the early stages of the program, from startup, developing that male engagement strategy that I talked about that addresses some of the key barriers to male participation in hygiene promotion activities, leveraging on platforms to encourage hygiene and sanitation behavior, and also making that deliberate effort to promote integration from the start. Community leadership buy-in has been important as well, and of course adaptive management, making sure that that culture of learning as we implement and building into the implementation is key. So as part of the key learnings on the next slide, building in adequate time and resources for qualitative research, and making sure that this is built in early on in the program, and utilizing the research to inform programming, and also tapping into available expertise, ProWash, Ideal, Tango, the sort of support that they have shared with us as a program. And then the final slide. So in conclusion, what's really important for us going forward, and in terms of next steps, is sharing the findings with the Ministry of Health at the national level, at provincial level, at district level, and utilizing different platforms to do so. Documenting the findings, which we have done, and sharing them with other development partners to inform future programming. That's very important as well, and that's key for us. And having this webinar has been part of that process of documenting the findings and sharing them with others. And those findings are also have been put together into a learning brief, which will be shared with the participants. And I think that's the end of the Amalima presentation.
Great, thank you so much, Pamela. Pamela has shared her email address here, and Amalima is also pulling together a website with a lot of the findings, not just from this work, but from the DIFSA more broadly. That website is not yet live, but we can most certainly share it when it is, if you're interested in seeing more of the documents from Amalima. Before we go on to Karen and Ellie's presentation, we'll just take a few of the questions that people have put into the Q&A box. So Pamela, first of all, a question that came in is, could you clarify when the key motivators were identified? Was it pre-intervention or through the research process?
The key motivators were identified through the actual research process that we undertook as a program.
Okay, great, thank you. Regarding the motivators, what process has been conducted to identify the barriers?
Okay, the barriers were actually identified as well in the same way through the qualitative research. So we had different focus group discussions that we conducted with the different groups. And we had, as part of the qualitative research, we came up with the tools and came up with the different questions that would help us to pose to the CHC groups as well as the as well as the agri-tech officers to find out more about what those specific barriers were.
Great. And there were also those interviews with the environmental health technicians as well.
That's correct.
Great. Can you please provide more detail on the amount of savings per family and cost of the latrines built?
Okay, so in terms of the savings per family, so the way that it would work, so for the VSNL to actually start up, there's a lot of self-selection that actually happens. So it's a small group, it's much smaller than the CFC. It could be about 5 members or a few more members than that, it could be up to 10. And they come together based on self-selection, based on trust, and they agree in terms of the amount that they contribute on a monthly basis, and they make those contributions. So one member might have to sell something, maybe small livestock, maybe a chicken, in order to be able to raise that startup capital to inject into the savings. So that's how it would actually work, and they would make small contributions month to month basis. In terms of the cost per latrine, so a lot of the cost that goes into latrine construction is the cement. So it's the procurement of the cement, and the cement is about $10 US a bag, and 7 bags are actually procured by the family to construct the latrine that is recommended in Zimbabwe, the UBVIP. There's also the cost of the labor, a local builder, so it's usually a local community builder. The local community builder can be paid in cash or they can be paid in kind. So it could be small livestock or it could be actually cash. So those are the key resources that come together. In terms of things like river sand, they would get that locally from the areas that they, from within the community. And all this is put together to contribute to the latrine construction.
Okay. Great, thank you. And so we had a couple questions that came in around the program's approach to gender integration. The first one is, how was the program's gender integration help to improve on latrine construction? So how did the program's approach to integrating gender really help to improve on latrine construction?
Okay, so we leveraged on the male, we call it the male champions approach that we ran with as a program. And that sort of gave us an entry point to get men to participate more in the hygiene promotion activities. And what we've seen as well is that a lot of the men, once they start participating, will contribute even to some of the labor intensive work that is undertaken. So it could be the digging of the actual pit for the latrine. So the men participate in that way. It could be the fetching of water, fetching of river sands, bringing the resources together. And some of the men are semi-skilled builders within the communities, and they contribute in that sort of way. So in some of the communities, what we did see was that though some of the men were not taking part in the health club activities, they were supporting the families by being available to undertake some of these labor-intensive roles in latrine construction.
Okay, great, thank you. And then another question came in around how they noticed that your project indicators were a bit general and not disaggregated by gender. How were you able to, was some data collected that was gender disaggregated, and how could you use that for your program to be more gender responsive?
So for that, in terms of the data that we collected, it was more around number of men participating, or proportion of men that were participating, number of women participating in the community health club activities. So in retrospect, and maybe going forward, this is something that we would, if we were given an opportunity to start a new program, certainly be sensitive to and look at ways in which we can collect a lot more data that can tell us much more around this area. But for now, we've got the data that talks about the number of women, the number of men, and about 14% of the community health club participants are men. So by nature, if you look at the hygiene promotion activities, when we started this program, they're being largely regarded as activities for women, just because they're hygiene related. So we had to do a lot of work in the community in terms of engaging stakeholders, engaging community leaders. And we even went with an approach that encouraged the formation and the support of all male community health clubs in order to get more men to participate. And we do have successful examples of some all male community health clubs that are actually continuing within these communities. 14% might seem a lot in terms of male participation, but remember, a lot of the men in these communities are economic migrants that are outside of the country, and what you already have is a lot of women who are head of households within these communities. So we see that as something that we can celebrate, because some of these approaches that we have adopted to get men to really worked within the context that we're operating.
Great, thank you. And then just one more question before we move on to Karen and Ellie's presentation. The high increase in safe water storage was remarkable. Although not discussed in this study, what could have been the reason for this high uptake?
Okay, so for this one, we think a lot of it has to do with the fact that it's easy to actually adopt this behavior that was being promoted. And a lot of the members within the CHCs were quick to adopt this. And a lot of the sessions that were covering the water storage are conducted early on, soon after the formation of the community health club. And once they're covered early on, some of them become refresher sessions. But we found this was a practice that was easily adopted by communities. And I guess it also helps that Ministry of Health, getting Ministry of Health support in terms of promoting some of these practices that are easy. Maybe it's more like the low-hanging fruit, but these are some of the practices that are much easier to actually promote and for people to take up within the communities.
Great, thank you so much, Pamela. And so there has been a lot of other questions that have come into the chat box. We'll take some of these live after Karen and Ellie's presentation, and some of these will be answered. We'll just type in the answers to some of your questions as well. So now I'd like to turn it over to Karen and Ellie. Karen is with Ideal, and Ellie is and Tango International, and Ellie is with Tango International. Next slide.
Great. Thank you so much, Nicole and the ProWash team, and also to Amalima for the invitation to join you today, but also throughout this entire process. I think this is a really exciting example of collaboration between ProWash bringing in your sectoral expertise together with some technical assistance from Tango and Ideal focused on research methods and qualitative research design. And then Amalima with your observations and findings on the ground and some interesting questions that were raised around some unexpected findings and some interesting dynamics. So it's an interesting example of a collaborative approach that I think we've all learned from, and as a result, we've gained some interesting insights around, but also a really good example of a process. You know, Pamela, you shared earlier on your findings from the quantitative study, those really remarkable changes between the baseline and the end line. And I think that's one model of qualitative work that's really interesting, using qualitative and quantitative methods in an iterative way, where your qualitative findings your qualitative analysis can be used to sort of get under those dynamics. You saw an interesting relationship between participants in village and savings loans and income generating activity interventions coupled with latrine uptake. So there was a signal to say, okay, what's going on here? Let's investigate these dynamics. So it's a really interesting use of a discrete study to do what qualitative research can do best, understanding those dynamics. Secondly, you used qualitative research to really get at those clusters of interventions, but also some of those topics that are a bit more delicate and that we don't often get really keen insight into in our quantitative findings. Looking at issues around shame and embarrassment, the sort of sensitive topics that we can use our qualitative methods to investigate, coupled with the role of traditional beliefs or community leaders. So in all of those aspects, I think it's such an interesting example. I appreciate the previous poll findings. And I'm going to just pause here. Nicole, I see you've got the poll question up now.
Sorry, the second poll question I have up now. Yes, what are the barriers to conducting qualitative research for WASH in your program?
Okay, great. Just want to make sure everyone has a chance to fill out that second poll. But I also am referring back to and thinking in my mind about the first poll where over half of you indicated that you are indeed using qualitative methods. And a third, perhaps not. So I really appreciate the mix that we have there. But I also really appreciate the 12% of you that said, I'm not quite sure. And as people working in the field, as M&E officers, as technical assistants, we're always gathering information. And a lot of that information is qualitative, it's perception based. So we're collecting information, but it's not necessarily always in a very coherent or systematically designed way. And so I again applaud Amalima for recognizing we have this interesting relationship here between people who are participating in VSLAs and IGAs and the uptake of some WASH practices and latrine construction. And we want to look at this in a systematic way. I think we started our conversation together in the latter half, or the latter quarter of 2019, with a question around a set of tools that could be constructed to dig into that particular question. And again, I really want to congratulate Amalima and the team for being interested and enthusiastic really about stepping back from the tools and looking more broadly at a comprehensive and coherent qualitative research design to investigate that, of which the tools were one component. What we want to highlight today is just the importance of having that well-founded research question. Our qualitative methods are never, there's no equation, there's no formula. It's a series of decisions that we're making at various steps along the design process. And those steps follow from a well-articulated objective and research question. And so that's where Amalima really started and then developed a protocol that they implemented in order to collect information, and then to analyze it and present it here today. So it's been a really exciting and coherent process. And with that, I really want to turn it over to Ellie, my colleague at Tango International, who's been working more closely with on the specifics of the research question and design choices. Again, just highlighting that, first we start with that question, and then we design a protocol with a series of steps that help us to implement that research, just as we would with any quantitative study. So over to you, Ellie.
Thank you so much, Karen. We really appreciate this collaboration, as Karen mentioned, and we think the opportunity to be able to speak about the research design and protocol process that we've been working on along with the Amalima team and the ProWash team. So as Pamela has demonstrated in her presentation, the Amalima team has vast knowledge on WASH practices, including CHCs in the program area. And so we have a very strong purpose that frames the sort of umbrella under which we're designing our qualitative study, which is to investigate the integration of these savings, IGAs, lending approaches in CHCs, which in turn become CHC pluses, in order to improve hygiene promotion activities, in this case, latrine construction uptake. And so from the purpose, we were able to work with the Amalima team on developing the types of research questions that the team wanted to explore. So we have the 3 research questions that were developed that were driven by a hypothesis. And these allowed us to understand what do we need to know and how do we obtain the information that we need to know. So we wanted to essentially capture the learnings on the characteristics that have contributed to this diversification into the broader range of savings and livelihood activities, which suggests that that these groups may continue with these activities after the close of the project. And so the 3 questions that Pamela and her team worked on, does that diversification improve the latrine uptake and construction? What are the motivating factors to constructing latrines, and what are the limits for CHCs that have not diversified yet? And so as part of the research question process, we wanted to ensure that we had an adequate sampling strategy that met certain selection criteria. So what does that mean? That basically means that we wanted to understand who do we need to mobilize for this type of study. Pamela mentioned, the gender lens, as well as the lens, the approach of the poorest of the poor. And so we knew from the beginning that we wanted to include in our sampling selection process women as well as men, adolescents, youth, but also the disabled and the elderly. So a variety of different subgroups of the communities in which Amalima is working in. So we essentially wanted to ensure representation from all the groups in the community, while also ensuring key selection criteria are met so that we have a range of variation, which is key. So the Amalima team decided to underline specific criteria in terms of when the CHC was formed, for instance, the types of CHC and the members of each CHC, what livelihood activities they employ, as well as the proximity to the markets and the amenities in the area. And so from the research questions and the sampling criteria and strategy, we also made sure to look back at the programming documents that Amalima had. And so this program had already existed for a number of years. And so we had the fortune of having enough program data and documents to be able to inform the purpose and the research questions, which in turn helped us refine the types of methods and data collection tools that we wanted to employ for this specific study. So we developed a series of topical outlines, each with categories of information that gathered the data that stemmed from the 3 research questions. And each topical outline was geared towards the focus group discussion dynamic, as well as a key informant individual interviews. So we knew that the Amalima team had, as we said, as we see from the presentation, vast experience in the area. They knew the context. There was an experienced team of researchers, and the tool was pre-tested, which is an important part of this process to ensure that the topical outline is in fact gathering the information that we need to answer our questions, our research questions. The Amalima team spent about a week collecting data with teams that had facilitators and note takers, and there were periods of debrief where the team was able to spend time and reflect on the information that was being gathered in order to continue the data collection process. And finally, the data was organized. It was coded in Excel matrices in a way that facilitated the team, the Amalima team, to review and begin the analysis process. So what were the themes? What were the patterns that emerged from the data? Were there any outliers that needed to be understood? And this was all coupled with the observations that the team on the ground was able to gather during their data collection process, along with a very important step of triangulating with the Amalima team's annual CHC outcome monitoring quantitative data to be able to inform the analysis process and then provide a report that documents the study and the research question answers. Next slide, please. So we wanted to quickly, briefly go over a series of key principles of qualitative research. And we really appreciate that you all spent a few moments in the beginning of the webinar answering about your experience in qualitative research. So we appreciate that. And as Karen mentioned, we're constantly collecting data on the ground, and you as implementers are clearly the experts in the context and in the areas. And so it's a matter of understanding, valuing the types of lived experiences that we see on the ground. And in order to do that, we want to gather rich, detailed data that gives us stories that we're able to give meaning to. And so while this is a flexible process, it needs to be guided by a purpose. It needs to be rigorous enough to, that it flows from that overall purpose that we agreed on from the beginning. And so we need to ensure that the purpose is fit for that particular study. So it needs to be relevant and focused and appropriate for that study, and in a way that you're able to describe the uniqueness of the households and a community and the situation in that particular context in a rigorous and structured way. And so you also want to make sure that the purpose and the qualitative study it fits within the award cycle and the M&E system in a way that is well integrated with the overall M&E system, and so that you may have the qualitative research done throughout the life of the activity, for instance, beginning from the baseline, the midline, endline, or it could be more of an exploratory standalone study that's complementing ongoing program activities. And so
great. Thanks so much for going over both the design and using the Amalima experience as an example of a good protocol and a good implementation strategy, and also one that adheres to these core principles of qualitative research, which really were sort of wedded throughout the process. So I know we're going to have some questions about the qualitative approach, so we can come back to that at the end. But now if we can go ahead and switch to the next slide, because I know we're getting short on time. We just wanted to, these slides will be available for you after the webinar, but we just wanted to highlight a few key resources, and many of these are resources within resources. So first, in May of this year, so just last month, USAID, the Office of Food for Peace, issued its monitoring and evaluation policy and guidance. And we now have some guidance integrated around qualitative methods. So we're really excited about that. Hats off to Food for Peace and the Imini team there. In that guidance document, you will find in the annex a template per se that's used as a sort of a guideline for developing a protocol and then communicating with between Food for Peace and our implementing partners around our qualitative approaches. So please check that out. We also have links here for some information around how we are adapting our qualitative methods during this time of COVID-19. Obviously, this study was implemented prior to the onset of that. We're all adapting, so we invite you to take a look at those resources and then potentially join our qualitative monitoring and evaluation community of practice, which will be kicking off with an event in July. But again, we're all learning as we go, so we want to continue to share our experiences around qualitative methods. So and with that, we have a quick question. Ellie, back to you.
Thank you, Karen. So we wanted to kick off the segue into the Q&A section by going back to Amalima and the team, Pamela and the team. We wanted to understand, what has your experience been, designing and conducting this particular study, and what has been the value add to your team?
Okay, thank you so much for that question. This is Javlisiwe. So what we realized as we conducted this research was that our research protocol was very ambitious. We needed to make sure that we set clear and smart objectives. We also needed to narrow down the research questions. The previous presenter talked about the issue of making sure that your questions are to the exact point, they answer the questions or the areas we want to explore. So we also realized that we needed to narrow down our research questions. We also needed to go back to the drawing board and ask ourselves, why do we want to conduct this research? What is it that we want to find out? So we had to go back and make sure we modify the purpose and the objectives. We also find out that we needed to dedicate a lot of time to the research. Qualitative research needs a lot of work to be done. So it was good enough that we had a motivated and an enthusiastic team to go out there and collect data and analyze and present authentic findings. So what we also realized during the study was that thematic analysis is quite time consuming. It needs a lot of skill to analyze the data and be able to present sound results. So as we were analyzing our data, we had to make sure that we do not lose information as we translated from the local language to English. Because when we're collecting data, much of the information was scribbled or written down in the local language, and we translate a lot of it. So finally, what I can say in a nutshell is that we are glad to have had great support from ProWash, Tango, and Ideal. With their guidance, their technical expertise, we managed to overcome the shortcomings that we had and managed to conduct this qualitative research. Thank you.
Great, thank you so much, Karen, Ellie, and Pamela for that response. I want to go ahead and share the results on the barriers to conducting qualitative research for WASH in your programming. It looks like close to 50% said that they do not have budget for this research. About a third say they need help in developing a research protocol, a third in identifying research questions, do not know how to analyze qualitative data, and do not have available staff. We're also around a quarter of those who voted. And so Karen and Ellie, I just wanted to know, do you have any tips for practitioners around maybe conducting a low-cost qualitative research for those that are, the half of the participants who talked about budgeting as an issue?
Great, thanks, Nicole, and interesting poll response and some interesting questions. First, I just want to point out that you'll see in the PNG link on this slide that Food for Peace, so if you're a part of a DIPSA activity, Food for a certain percentage of money towards its M&E activities. And this new PNG, policy and guidance document, certainly signals an increased prioritization of qualitative methods. So take a look at that, and I think one of the keys is to build that in from the beginning. Multiple ways to do that, either as an iterative, discrete study or approach, such as Amalima used, or as part of your monitoring system over time. In terms of costs, yes, and Pamela, we hear you, it's time consuming, and it does require skill. So I think you've made that investment. So there is that upfront investment. I think some of the things that we're trying to share and communicate, and this is through the PNG and some of the activities that IDEAL will be planning in the coming year, really try to emphasize some accessible, user-friendly tools. We prioritize operational findings and how we can do that, collect that information and analyze it in a timely way. And there are multiple strategies for that. So I would love to be a part of a conversation going forward where we could look at various options and designs that would enable a more timely and a cost-efficient approach for qualitative methods.
Great, thank you so much, Karen. And I just want to highlight again, if you're a Food for Peace partner, and there's questions around identifying research questions, developing a protocol, how to analyze qualitative data, we'd love to hear from you. Feel free to reach out, and we're happy to see how we can support you to kind of document these learnings around in WASH and through these qualitative research methods. So before we conclude, we're just going to take one more question, and this one will be for Amalima. And can you just talk a little bit about sustainability? What post-implementation strategies, including monitoring, have been put into place to ensure continuity on latrine construction? So what sort of post-implementation strategies and monitoring are in place to help support sustainability of the latrine construction?
Okay, thanks for that, Nicole. So what's really been key and what's really been important is to leverage on those linkages that have been supported by the project throughout implementing the Amalima project. So we worked very closely with the Environmental Health Department from Ministry of Health, from district level right down to community level in terms of the environmental health technician and the CBF, who is the community-based facilitator. Having those structures in place where the environmental health technician from Ministry of Health continues to support the community-based facilitator who runs the community health club activities, and making sure that those are strengthened will contribute very much to the sustainability. Something that we've really written on is around the intrinsic motivation of the volunteers that we work with. So we work, as we've worked with the CBFs, the 260 CBFs, a lot of them are intrinsically motivated because they're recognized and they're appreciated and they're valued by the communities that they serve. I think engaging local leadership has been key to this, and working closely with the structures that are already in place. So that recognition has contributed to their intrinsic motivation. A week ago or so, I was talking to some of the volunteers that are out in the field, and some of my team have also been out there. And we know that even with the COVID-19 situation, the community health clubs are continuing to meet. Their visibility is even more heightened because of the fact that a lot of what they're promoting are some of the strategies that can help people in communities to address or to prevent the spread of COVID-19. So community health clubs are very active in constructing TP tabs in communities, at business centers, disseminating some of the key hygiene promotion messages, even as we speak. And that's really contributing to their recognition, their motivation.
Great. Thank you so much, Pamela. Next slide. So I'd like to thank everyone for attending today. We didn't get to all the questions in the Q&A box, but we are out of time. I do want to highlight, though, that Amalima has pulled together a learning brief that really summarizes the methods, the results from this study, as well as broader lessons learned from implementation. And we'll be sending the link to you in the next few days so that you're able to take a closer look at that learning brief. And you can always reach out to ProWash or to Pamela if you have more questions around the methods, the results, or you want to see how you can incorporate in these techniques into your own work. And so before we close, we just want to highlight a few upcoming events. There's a Lives in Balance COVID-19 Summit for Health and Well-Being of Women, Children, and Adolescents that takes place on July 1st and 2nd. And this is being organized by the core group. And there is a WASH track that is being run during this online conference. And so we just want to share the link in case you might be interested in attending. ProWash and Scale are also launching the Making a Change Agent, an SBC resource for WASH, agriculture, and livelihood activities on July 14th in English and July 16th in French. And more information will be coming out in our newsletter soon. And finally, as Pamela mentioned, many of you are adapting to COVID-19 and your project activities and how you can address those key behaviors. And so we just wanted to highlight that there is a really interesting and useful resource that's available, the COVID-19 Hygiene Hub, where you can get fast and accurate technical advice, access a lot of resources, everything from how to do qualitative monitoring remotely to how do I develop a behavior change strategy during COVID-19. So we want to share that as well. And then next slide. Great, so thank you so much, and thanks to all of those who have voted. We'll take your input into consideration as we plan future events on qualitative research for WASH. And if you're interested in sharing your own work or receiving technical support, here is our information. So thanks again for attending, and a big thank you to Amalima, to Pamela, Wellington, Karen, and Ellie for presenting today. Thank you so much.